Welcome back to my channel Surgery Nuggets by Dr. Himashri. We are going to discuss the differences between cellulitis, necrotizing fasciitis versus abscess, how to identify these conditions clinically and treat them accordingly. Let's start with cellulitis. So what is cellulitis? By definition, cellulitis is a non-suppurative, invasive, spreading infection of the subcutaneous tissues, which is usually related to the point of injury. Cellulitis is usually non-suppurative, but can it be suppurative? Answer is yes. It can be suppurative, and then there will be the skin, and in severe conditions, especially in diabetic patient, it can lead to gangrene of the part affected. So what are the causes of cellulitis? The most important cause is Streptococcus pyogenes infection. Also, other gram-positive organisms are involved. Gram-negative organisms like Klebsiella, Pseudomonas are also seen. Cellulitis is common in diabetic patient, old, debilitated patients, or also patients with immunosuppressed conditions. Now, clinical features of cellulitis. Cellulitis is a diffuse swelling of the subcutaneous tissue which is rapidly spreading. The skin appears red, shiny, and stretched warm skin. Pain and tenderness present on clinical examination. There is no well-defined edge of the swelling. I'll show in the next picture. There is no well-defined edge, no pus. Lymph nodes are usually tender. The regional lymph nodes draining the area, they become enlarged, which is a picture of acute lymphadenitis. In severe conditions, patient may have fever, tachycardia, and the infection can also lead to sepsis, ultimately leading to conditions like hypotension, septic shock. In case of children, we have to be very careful so that we do not miss osteomyelitis. So in children, joint examination, especially knee joint examination, is very important. Sometimes the cellulitis may be because of the underlying osteomyelitis. So to rule out osteomyelitis, we have to do a proper joint examination. Also, in adult, in case of scrotal cellulitis, if there is scrotal cellulitis, then always look for any extravasation of urine. We have to look for. This is a picture showing cellulitis of lower limb. The first one, you can clearly see all the clinical features that I have mentioned. Here you can see the left lower limb is red, shiny, edematous. You can see this is swollen than the right limb, and on examination you may find pitting on pressure. So we can also get pitting edema. A patient will have pain, and there will be tenderness, raised temperature, but there is no well-defined edge. The edge is very ill-defined in case of cellulitis, and on palpation we may find the skin is indurated. So this is a case of cellulitis. The second picture is also, these are also cellulitis of the lower limb, but here you can clearly see there's a trivial trauma. Some prick or some trivial trauma was there, and following the injury, the limb gradually became swollen. So coming to the next picture, it is a case of orbital cellulitis. You can see this area is red, swollen. So this is a case of orbital cellulitis. Orbital cellulitis are dangerous because it can spread through the ophthalmic veins into the cavernous sinus and can cause cavernous sinus thrombosis, which is a fatal condition. Next is a picture of Ludwig angina. So this is a picture of Ludwig angina. It is a rapidly progressive polymicrobial cellulitis of sublingual and submandibular space. You can see the investigation part. So what are the investigation we do? Definitely we are going to see the leukocyte count. Total leukocyte count will be raised. In case of cellulitis, platelet count usually decreases. We have to look for blood sugar. As I have mentioned, these cases are more common in diabetic patients. So blood sugar, HbA1c, urine test for blood and protein level should be checked. LFT, liver function test, is also important. In severe cases, we have to look for kidney function test. Serum creatinine and serum electrolytes are also monitored in these patients, and they are usually managed in ICU care. So venous Doppler and ultrasound of the soft tissue also done. This is an ultrasound showing cellulitis of the soft tissue. So what is this cobblestone appearance? What is cobblestoning? See, these are bumpy, irregular fat globules. Can you see? These are bumpy, irregular subcutaneous fat globules. And among those fat globules, this black color is the fluid, edematous fluid. Edematous fluid is marked here. See, this is the edematous. So cobblestoning is typically seen in case of cellulitis on ultrasound. Because of the chronic inflammation, the fat globules are bumpy, irregular, and there is septations, and among those septations, edematous fluid is collected. Okay. Now coming to the treatment part. So what is the treatment for cellulitis? Definitely we are going to start a broad spectrum antibiotics. Elevations. Limb elevation to reduce the edema. Dressing. In case of cellulitis, we use glycerin magnesium sulfate dressing. So the magnesium sulfate acts as a osmotic agent which helps to reduce the edema by drawing out glycerin. It acts as a very thick viscous moisturizer and prevents the dryness of the skin, and also it helps to keep the magnesium in contact with the affected area. So around 20 gram of Epsom salt, around 20 gram of glycerin magnesium sulfate salt is mixed. Magnesium sulfate is mixed with 100 ml of glycerin. 20 grams. We apply the soaked gauze smoothly directly over the affected skin and wrap with a pad of cotton and secure firmly with a roll bandage or crab bandage. Then we have to control the sugar level, blood sugar level, strict control of the diabetes, and especially for patients with septicemia, ICU care and intense monitoring is done. Coming to necrotizing fasciitis. So what is necrotizing fasciitis? It is a rapidly progressing skin and soft tissue infection associated with necrosis of dermis, subcutaneous tissue, superficial fascia, deep fascia or muscle. So the definition of necrotizing fasciitis, it includes varieties of condition. Namely Fournier's gangrene, or we can see clostridial myonecrosis also, gas gangrene, then Melanie's gangrene. So this is a necrotizing fasciitis of lower abdomen. So Melanese gangrene is a necrotizing fasciitis of lower abdomen, and here we see both the streptococcus and staphylococcus infection are present. Both organisms can be seen. Here showing the necrotizing fasciitis of the lower abdomen. Here you can see spreading skin and soft tissue infection, which is so extensive. And usually trauma is a common precipitating factor for majority of cases of necrotizing fasciitis. Muscles are usually not involved in necrotizing fasciitis. The mortality for necrotizing fasciitis is very high, 10 to 25%, and the common characteristics for these conditions are irreversible and rapid tissue necrosis seen, leading to sepsis, and ultimately it is very fatal. Sepsis, and it is highly fatal. Causes mainly because of gram-positive cocci. Streptococcus pyogenes most common organism involved, and 80% of these infections are polymicrobial. Coming to the clinical features of necrotizing fasciitis, 90% of cases have erythema. 90% of cases have erythema, warmth, and pain. Crepitus, bulla, and skin necrosis also seen. So traditionally we do finger test. What is finger test? Under local anesthesia, we give a incision around 1.5 centimeter over the affected part, and then by using our fingers, if we probe down the affected part up to the deep fascia, and the deeper tissues, we probe down the suppose this is the necrotizing fasciitis area. So if we push down the affected part up to the deep fascia, and the deeper tissues dissect easily with minimal or lack of resistance, there will be no resistance if we push it down, then the finger test is called to be positive for necrotizing fasciitis. Lack of bleeding, there will be lack of bleeding in necrotizing fasciitis, or fluid extravasation, dish wash like fluid is extravasated from the area. Biopsy should be taken and tissue culture, pus culture should be sent. Now there are certain clinical stages. We can divide the clinical features into 3 stages. The stage 1 is when patient will complain of fever, patient will have erythema, edema, warm skin, and tenderness present. Second stage is the stage of blisters with bulla formation. And lastly, the area will be hypoaesthetic or no sensation at all. Crepitus will be present, tissue necrosis, and hemorrhagic bulla are seen. So these are 3 stages of necrotizing fasciitis. Coming to the investigations, the first and foremost blood investigation is total leukocyte count to see how severe is the infection. CRP will be also raised. Hemoglobin level should be seen, because main surgical management of necrotizing fasciitis is extensive and aggressive surgical debridement, that we need to have a proper hemoglobin level. If the hemoglobin is low, then we may need blood transfusion for these patients. Then serum electrolyte is also important. Blood sugar level should be examined, and serum creatinine level to know the kidney status. Ultrasound, CT, these are some radiological investigation we can do. So what we see on CT scan, for necrotizing fasciitis, CT is most commonly favored modality. What we see, we can see gas in soft tissue, multiple fluid collections, and inflammatory changes under the deep fascia. So this is a CT film showing necrotizing fasciitis. What we see here, Can you see? These black dots are the air bubbles. These are the air bubbles or the gas produced because of gangrenous changes, necrosis, and the fats trending. So below the deep fascia there is inflammatory changes can be seen. Below the deep fascia inflammatory changes can be seen. So this is necrotizing fasciitis. Scoring system to assess the severity. This is called laboratory risk indicator for necrotizing fasciitis score. Laboratory investigation values. Number 1 we see CRP level. Second, total WBC count. Third, we see hemoglobin. Fourth one is sodium. Fifth one is creatinine, and next is glucose level. Based on different value, we give scores to each laboratory parameters. If LR, if this necrotizing fasciitis score, if the score is less than 5, we say there is low risk for developing necrotizing soft tissue infection. That is, probability is almost 50%. If score is 6 to 7, there is intermediate risk factor associated with it, and probability of leading to soft tissue infection is 50 to 75%. If the score is more than 8, it is considered as high probability, almost more than 75% risk of necrotizing soft tissue infection. Now coming to the treatment part. The mainstay of the treatment is surgical debridement. Radical wound excision of the gangrenous skin and necrosed tissue at repeated interval is done. So early aggressive surgical debridement is the mainstay of the treatment for necrotizing fasciitis. Then definitely we go for broad spectrum antibiotic and IV fluid also. So what is resuscitation? For hemoglobin level, if it is low, we have to go for blood transfusion first before any surgical debridement. Culture is done, blood culture is done, and also electrolyte monitoring should be done for these patients. Electrolyte monitoring. Next, if the patient is diabetic, diabetic control should be done. And vancomycin are often required as life-saving drugs in these patients. Once patient recovers and the granulation tissue becomes healthy, we can go for skin grafting. Now, the last one is abscess. So what is abscess? Abscess is nothing but a localized collection of pus in a cavity lined by granulation tissue, and it is covered by a pyogenic membrane. So this is the definition of an abscess. But what is pus? Pus, it contains multiplying bacteria. So pus contains multiplying bacteria, dead WBC, toxins, and necrotic material. See in this diagram, this is the skin margin. This area is the infected part. You can see a swelling, and below it there are bacteria. These are multiplying bacteria, blue color. These are multiplying bacteria, and this white structure is the pus, that is WBC. So bacteria, WBC, and the necrotic material together, they form the pus. What are the clinical features? What are the clinical features for abscess? Any kind of abscess, they are usually smooth. It is a localized swelling which is smooth, soft, with visible pus point. Abscess will be fluctuant. There will be local rise of temperature, and once abscess forms, the pain is typically throbbing in nature. Pointing tenderness and brawny induration is also seen. Fever may be present with chills and rigor, which is typical for abscess. So this is a picture. So these are some pictures of abscess. Red, there is a swelling, and this is the most fluctuant, seems to be the most fluctuant part of the abscess. Here you can see definite pus point in the abscess. Here you can see definite pus point in the abscess. Coming to the investigation, for abscess, TLC will be raised, RBS and urine sugar test also done to rule out diabetes. Blood sugar and urine sugar test also done to rule out diabetes, because abscess are also common in diabetics. Blood culture, ultrasound of the part, these are some of the useful investigation. CT or MRI, not done in all cases, but definitely for brain or thoracic abscesses. This is drain, we sent it for culture. So this is the ultrasound image of abscess. So this is the ultrasound image of abscess. Here you can see the abscess is a localized collection of pus. So the margins are well defined in case of abscess. It is a hypoechoic area. Hypoechoic area is black, black, black. But you can see there are certain irregularities in the hyperechosity. So this is because of presence of fluid and pus inside this cavity. And most important is posterior enhancement. Can you see? This is the abscess. Posteriorly, here you can see this is hyperechoic area. This light area is posterior enhancement. Posterior enhancement. This is due to, posterior enhancements is due to the light rays passing freely, the light rays passing easily through the fluid. Because of that, posteriorly there is enhancement. Now here I have compared the ultrasound image for cellulitis and abscess. So this left one is a case of cellulitis, and this one is ultrasound of an abscess. Can you see? In case of cellulitis, these are subcutaneous fat lobules appearing as a cobblestone, bumpy irregular fat lobules which are thickened, and also there are fluid in the paraseptal area. Black, black, these are fluid filled paraseptal space. But this is not localized. There is no localized collection. On the other hand, for abscess, there is a localized collection, well-defined margins, hypoechoic area, and most importantly, posteriorly there is enhancement, posterior enhancement. Fine. So what is treatment for abscess? Definitely we'll give antibiotics for these patients. The mainstay of treatment is incision and drainage. Wherever there is an abscess, you have to drain it. So Hilton's method. What is Hilton's method? Hilton's method is mainly for the areas where vital structures like major blood vessels are present. In those areas like neck or axilla or groin, if any abscess is present, this method is applied. What we do area, first we give local anesthesia to the area, then with a stab knife we put a incision over the most fluctuant point. So and then we insert a Lister's sinus forceps. This is a sinus forceps, also called as Lister's sinus forceps, by closing the two blades of the forceps. We push it. So this is a kind of blunt dissection. Blunt dissection. We push the Lister sinus forceps until it reaches the deep fascia. So we push it until it reaches the deep fascia, and then we puncture the deep fascia, open the blades of the sinus forceps, and then we draw it while the blades are still open. And we always open the blades parallel to the vital structure, that is the parallel to the major blood vessel. We open the blades and then we take it out. After that we insert a finger. You can see in this image we insert a finger, and with the help of blunt dissection with the finger, we break any loculi, any remaining loculi present in that abscess cavity and surrounding space. Then evacuate the pus completely, send the pus for culture sensitivity, and then we may put a drain if needed in this space, or packing is done. Now coming to the last slide, this is a difference between us. This is a slide showing the difference between cellulitis and abscess. So first of all, cellulitis, it is a acute condition, whereas abscess can be chronic. In cellulitis, there is severe and generalized pain, but in case of abscess, the pain is localized to the area. Cellulitis, it is ill-defined, diffuse borders are seen, large area is involved, and for abscess, small area is involved, usually small area is involved, and well circumscribed. It is localized and well circumscribed area. On palpation, cellulitis has indurated margins and abscess is fluctuant on palpation. In cellulitis, usually there is no pus, but in case of abscess, pus is present. Cellulitis bacteria can be aerobic, abscess usually anaerobic bacteria. This is for today. Like and share and kindly subscribe for more such videos. Thank you.